Now, using all the clinical information that we have learned, guys, the classification of squint, the test, the phoria, the tropia and everything, we will now at last be discussing the theory of squint that we usually read in our third year, the clinical features. So to read that, we will be discussing basically 4 groups of squint. If you remember the classification, let's start from the bottom of the classification. Paralytic squint, restrictive squint, 2 groups. Once we are able to complete both of these, we are able to complete incompetent. So the third group will be committent squint. Committent, incompetent done, tropia done. Phoria, nothing to discuss, only under conditions of stress. Tropia and phoria done, true deviation done. So the fourth group left will be pseudostrabismus. So we will be discussing 4 groups, everybody: paralytic squint, restrictive squint, committent squint and pseudostrabismus as topics. As soon as I say paralytic squint, I hope it is very clear to you that I am talking about cranial nerve palsies. So we know the popular way to remember the nerve supply: SO4, LR6, O3. Superior oblique gets supplied by the 4th nerve, lateral rectus by 6th nerve, and all the other extraocular muscles by the 3rd nerve. So basically, if I subdivide this topic into 3 parts, there will be 3rd nerve palsy, 4th nerve palsy and 6th nerve palsy. So the first topic that we'll be picking up, everybody, is 3rd cranial nerve or oculomotor nerve palsy. Okay. Now, first of all, I'll just ask you a basic anatomy question. Where is the nucleus of 3rd cranial nerve situated? 3rd cranial nerve? Yes, it is situated in the midbrain at the level of superior colliculus. The nucleus is situated in the midbrain at the level of superior colliculus. Okay. Then this nucleus can be divided into 2 parts. One is the main motor nucleus and the other part can be called as the accessory nucleus, which is named as, everybody knows, everybody, I hope, Edinger-Westphal nucleus. Edinger-Westphal nucleus. Now the main motor nucleus, everybody, supplies the extraocular muscles. What are the extraocular muscles, everybody? Superior rectus, inferior rectus, inferior oblique, medial rectus, levator palpebrae superioris. Now, why have I written levator palpebrae superioris as a single there? Because LPS is supplied by an unpaired nuclei. LPS is supplied by an unpaired nuclei. It's a lot of English, double meanings, that's all. Unpaired nuclei means that there is only a single subnuclei for both the LPS. Are you getting what I'm saying? If I say paired nuclei, pair means 2 things. So for superior rectus, there is a paired nuclei. Right nuclei, left nuclei. For inferior rectus, right nuclei, left nuclei. But for LPS, both the LPS are supplied by a single subnuclei. So it has an unpaired subnuclei. Are you getting my point here, everybody? Now, the other important question is that superior rectus is supplied contralaterally. Superior rectus is supplied contralaterally. The right nuclei will supply the left side. The left nuclei will supply the right side. Okay. Then, from the nucleus, everybody, from the nucleus, going through its course, 3rd nerve enters the lateral wall of cavernous sinus. See, I have not gone deep into the whole course of the 3rd nerve. I'm just discussing the important point as far as the MCQ here is concerned. Okay. Restricting myself to the ophthalmology. third nerve enters the lateral wall of cavernous sinus and passes through the superior orbital fissure, SOF, superior orbital fissure, within the annulus of Zinn. Okay, everybody? So within the annulus of Zinn, inside the annulus of Zinn, third. So these are certain simple points of anatomy that are used as MCQs. I just have told you those. Okay, guys? Now that we know the muscle supplied from the main motor nucleus, what are we left with? Edinger-Westphal nucleus. Edinger-Westphal nucleus supplies which muscle? Neuroophthalmology, pupillary reflex pathway, third nerve, Edinger-Westphal nucleus. Edinger-Westphal nucleus, third nerve, ciliary ganglion, short ciliary nerve supplies the sphincter pupillae muscle. As well as it also supplies the ciliary muscle. So the two intraocular muscles, everybody, the sphincter pupillae and the ciliary muscle get supplied by the Edinger-Westphal nucleus. So basically I can say that total of 7 muscles are supplied, 5 extraocular muscles, everybody, and the 2 intraocular muscles, sphincter pupillae and ciliary muscle, both parasympathetically controlled, everybody. Okay, done? Now, after we know this much, everybody, let's see the clinical features of a third cranial nerve palsy. Clinical features of third cranial nerve palsy. Now, before I move on to listing the clinical features for you, I would like to appeal to your common sense. What can be the clinical features of paralysis of a muscle? Think about it. Third cranial nerve is getting palsied. So let's say the superior rectus is getting palsied. If the superior rectus is palsied, what is the action of superior rectus, everybody? Elevation. So if superior rectus is palsied, there is no elevation. If there is no elevation, instead what is occurring? Instead, what is occurring, everybody? Instead, the eye is going down because the antagonist is overacting. So if the superior rectus is palsied, the eye cannot go up. Instead, it goes down. Another example, let's take medial rectus. What is the action of medial rectus? Adduction, inward movement. So when my third cranial nerve is palsied, everybody, my eyeball cannot move in because of the medial rectus palsy. Instead, the eyeball will go out because of the unhindered action of lateral rectus. So what do we understand? Superior rectus action elevation, clinical feature down, opposite. Medial rectus action inward, clinical feature out, opposite. So if I just want to summarize the whole paralytic squint in one line, I can say the clinical features are opposite to the action paralyzed. Am I clear? So focus on the name of the muscle, focus on the action, just try to remember that, just do the opposite and you will get the clinical feature. That is what I will be doing now, everybody. So let's start number 1. First of all, the muscle paralyzed is LPS, LPS paralyzed. What was the action of LPS, everybody? The action of LPS was elevation of upper lid will not be able to occur. Instead, what will occur, everybody? Drooping of upper lid. Drooping of upper lid, and drooping of upper lid is known as, all of us know, ptosis. So the clinical feature becomes what, everybody? Ptosis. Okay, simple. Number 2, I said 2 muscles are paralyzed, superior rectus, inferior oblique. Superior rectus and inferior oblique both are paralyzed. What is the common action of both the muscles? Superior rectus elevation, inferior muscles opposite action. So inferior causes elevation. So that means basically there is, I can say, limitation of elevation of eye. Yes. When there is limitation of elevation, the eye cannot go up. Instead, the eyeball will go down. And when the eyeball goes down, downward deviation is known as hypotropia. Yes. Number 3, everybody. Medial rectus is paralyzed. When medial rectus is paralyzed, everybody, what will be limited, everybody? What is the action of medial rectus? Inward movement means adduction will be limited. Adduction will not be able to occur. When the eyeball is not able to come in, everybody, the eyeball instead will go out. And out eye is known as exotropia, outward deviation. I hope there is no problem understanding this simple thing, guys. Write down the action, do the opposite, get the clinical feature. As simple as that. Now, if somebody asks you, everybody, let's say the question mentions in third cranial nerve palsy, what is the position of eyeball? What will you say? The answer is written for you on the screen. The position of the eyeball is down and out. Down and out. Am I clear to everybody? See this photograph. Can you see a down and out eye? Which eye, everybody? Focus at the left eye, everybody. The first thing you notice obviously is ptosis, drooping of eyelid. But if you carefully notice the eyeball which is visible here, it is down and it is out. Am I crystal clear to everybody? So down and out eye. Now, let's complete our clinical features. Number 4. Sphincter pupillae is paralyzed. What is the action of sphincter pupillae? Sphincter pupillae is paralyzed. What is the action of sphincter pupillae? Meiosis. That means meiosis is not able to occur. If meiosis is not able to occur, instead what you will see mydriasis. As simple as that. Am I clear, everybody? So I'm putting a cross to denote it cannot occur, okay? So mydriasis will occur. Or if I try to say it in a fancy way, because meiosis is not able to occur because my final muscle is paralyzed. If I throw light on the right eye or the left eye, will the pupil be able to constrict? No. I am trying to elicit which response? Neuro-ophthalmology, light reflex. So if light reflex is absent, I will say no light reflex. If my third cranial nerve is paralyzed, that particular pupil will never be able to constrict because now the final muscle is paralyzed. Okay? Number 5. Ciliary muscle is paralyzed. When the ciliary muscle is paralyzed, ciliary muscle has just one action. I can straight away write down loss of accommodation. Loss of accommodation. Or if I write it in a fancy way, accommodation reflex or accommodation is a part of near reflex. So I will say there is no near reflex. So it is just the way that the question is being asked. See, the information remains the same. We just need to be able to think of the ways the options are being framed. That's all, guys. Okay. So there is no light reflex. There is no near reflex. We know that there will be mydriasis and there will be loss of accommodation. Now, because it is a case of paralytic squint, everybody. Paralytic squint is a type of incomitant squint. Incomitant squint, diplopia is always present. But which type of diplopia? Which type of diplopia? Maddox rod, we have mentioned 2 words, crossed diplopia and uncrossed diplopia. If you remember, cross means X. So let's go back up to point number 3 and see which squint do we have? XO. Third cranial nerve palsy presents with XO. X means cross. So that means I don't need to think about it. I will have cross diplopia. As I've already told you, XO, the trick to remember is X means cross. So in every case of XO which occurs, everybody, whether we are testing it or whether we are clinically seeking it in a patient, there will always be a cross diplopia. The right eye image visible on the left side, the left eye image visible on the right side, as explained in the Maddox rod testing to all of you. Right, guys? So these are the 6 important clinical features. I hope you have been able to understand this. Now, if I show you another photograph, I hope you will be able to diagnose it also. Let's see this photograph, everybody. Let's see the first photograph. In the first photograph, what do we see, everybody? In the first photograph, we see ptosis plus down and out eye. My diagnosis is clear from this photograph only. But what if I want to examine all the ocular movements? Let us try to examine all the ocular movements. In the second photograph, I have asked the patient to look up. The left eye has been able to look up, but the right eye has not been able to look up because there is limitation of elevation. Yes. Third photograph, everybody. In the third photograph, we see that we have asked the patient to look towards the right side. Right side means right eye is doing what, everybody? Abduction. Right eye abduction can occur, yes or no? Yes, because lateral rectus is functioning. Lateral rectus is not paralyzed. So abduction is present, which it should be. Then in image 4, everybody, what do we see? We have asked the patient to look towards the left side. In left side, the right eye will need to do adduction. Has adduction been able to occur? No, because medial rectus is paralyzed. So adduction is absent. So all the clinical features we have written can be seen in this. Ptosis, limitation of elevation, adduction is absent, and that is why the eye is down and out. Thus proving to us very clearly that this must be a case of third cranial nerve palsy. Okay, everybody? No confusion about this, I hope? Yes? Now, after we know the clinical features, after we understand how ridiculously easy they are to understand, let's talk about some special clinical features based on some specific causes of third cranial nerve palsy. Number one, everybody, if it is diabetes or hypertension, they present with third cranial nerve palsy with pupillary sparing. Third cranial nerve palsy with pupillary sparing. The pupil is spared. The pupil is spared means what, everybody? That which muscle will not be affected? Sphincter pupillae will not be affected. That means you will see all the clinical features, but mydriasis will not be seen. Pupil will be normal. When my pupil will be normal, I will say light reflex will be present. Only the near reflex will be absent. You understand the difference, everybody? Because my sphincter pupillae is not affected, my light reflex will be present. My pupil will be able to constrict also to light. Okay? Secondly, if it is a case of uncal herniation, then the case presents with only mydriasis. Only mydriasis is seen. Okay? That means only the sphincter pupillae will be paralyzed, all the other muscles will be left. Now, why is this number 1 and number 2 occurring, everybody? There is a simple reason for it. I'll just draw a rough diagram. Let's say this is my nerve, everybody. Yes? Nerve fibers get supplied by arteries. So there is a superficial artery and there is a deep artery. The deep artery is supplying the central fibers and the superficial artery is supplying the peripheral fibers. Okay? All the vascular diseases, everybody, vascular diseases affect the deeper, or I can say the central vessels. Thus, they spare the peripheral nerve fibers. Peripheral nerve fibers are supplying sphincter pupillae. Do you understand the simple explanation what I am saying? Diabetes and hypertension being vascular disorders, they will affect the major arteries, the central arteries, everybody. The central arteries, if they are affected, the nutrition to the central nerve fibers which are supplying all the extraocular muscles gets affected. But the peripheral nerve fibers do not get affected. So the peripheral nerve fibers are supplying the sphincter pupillae, so the sphincter pupillae is spared. But when we talk about uncal herniation, everybody, uncal herniation is a compressive lesion. The compressive lesion will compress this area, everybody. This area means it will compress the peripheral artery. When it compresses the peripheral artery, only the peripheral nerve fibers are losing their nutrition and their function. So only mydriasis is being seen because only sphincter pupillae is getting destroyed. All the other nerve fibers remain intact. Okay, everybody? Are we clear about this? Very simple fundamental of why diabetes or via uncal herniation causes special clinical features. Now, after this, everybody, the third special clinical feature is in cases of what you must have read in your anatomy, or you should read, everybody, Benedict's syndrome. Benedict syndrome presents with third cranial nerve palsy plus flapping tremors. Contralateral extrapyramidal signs, I can say. Lesion through the midbrain, everybody. So there are three syndromes named as Benedict's, Weber's and Nothangels, in which the lesion is through the midbrain, everybody. Yes? So if the lesion is through the midbrain, because the nucleus is situated in the midbrain, the third nerve is affected. So in Benedict syndrome, there is third cranial nerve palsy, but along with flapping tremors, and the lesion is through the red nucleus. So just basically concising the anatomy, if you remember it. I remember it by B, F, R. If you talk about the MCQ points, these are the points. Benedict syndrome, flapping tremors is also seen, and the lesion is through red nucleus. BFR, that's how I remember it as. Okay? Boyfriend, breakfast, whatever you can remember it as the short form for. Then number 4, everybody. Benedict syndrome. The second syndrome that we know is Weber's syndrome. In Weber syndrome, what occurs, everybody? Again, third cranial nerve palsy plus something additional, contralateral hemiparesis. Okay, everybody? Contralateral hemiparesis, and the lesion is through cerebral peduncle. Okay? I remember this as WCH. WCH, which, yes. If I say WCH, it sounds like which, okay? Or you can say which, WITCH, which, WCH. Weber's cerebral peduncle hemiparesis. That's my simple trick to remember it, guys, okay? Now, the last scenario where we have some kind of change of clinical features, special clinical features, is a nuclear third cranial nerve palsy. Nuclear third cranial nerve palsy. I'm not talking about a nuclear war here, guys. Nuclear third cranial nerve palsy means when the lesion is affecting the nucleus of the third nerve. When the nucleus is getting affected, then you have to take into account the contralaterality of the superior rectus and the fact that LPS is supplied by an unpaired nuclei. So what you will see, everybody, you will see bilateral ptosis due to unpaired nuclei for LPS. Yes. So whether I have a right third nucleus lesion or a left third nucleus lesion, LPS will go both sides. But I will have a contralateral superior rectus weakness. Because as we noted, superior rectus is supplied contralaterally. Am I clear to everybody? And both these points together are known as Daroff's rule. Just remember Daroff's rule. Okay? Daroff's rule states that if the lesion is at the nucleus based on the anatomy, these are the two specific special clinical features seen in case of a third cranial nerve palsy. No confusion, I hope, everybody. So a little bit of anatomy, a little bit of understanding, and I hope we are done with the special clinical features. After we are done with this, everybody, what should be the treatment of third cranial nerve palsy? We know the clinical features, we have been able to diagnose, but then what is the treatment? Should we give some drugs? Have we read steroids somewhere? Yes, steroids we have read. This is how the memory confounds it. We have read somewhere that in some cranial nerve palsy steroid is given. When an MCQ is asked, we try to go to the closest option possible. But unless we understand the fundamental, we get it wrong. Steroids are used in Bell's palsy because ideally the common cause of Bell's palsy, facial nerve, 7th cranial nerve palsy, is inflammation due to reactivation of some herpes infection which was dormant. Because the cause is inflammation, that is why we give steroids. In third cranial nerve palsy, we have not mentioned any inflammation anywhere. Yes? What is the treatment? The treatment is actually just one word. Observation. I know. Observation for at least 6 months. Observation for at least 6 months. Why observation? Now that's the question. As third cranial nerve can regenerate. As third cranial nerve can regenerate. Now, if you know a little bit of your neurophysiology, you may know that if a nerve is covered by a covering called as neurolemma, which is formed by Schwann cells in PNS and oligodendrocytes in CNS, then the nerve or the neural tissue has the property of regeneration. So we are giving the nerve 6 months to be able to regenerate. In most cases, it will regenerate, everybody. Yes, it will regenerate. The clinical features will the clinical features will improve in 6 months. And we would know that the nerve is regenerated, so we don't do anything. The only other option we have is surgery. If it is not improving at all, but it is very rare. So I'm not going into which surgery, blah, blah, blah. Right, guys? But due to this regeneration we have mentioned here, this regeneration can actually be faulty. So now comes the topic aberrant regeneration. Basically, when the nerve fibers are regrowing, they don't specifically know where to go. It is like you were doing your homework first, but then you started copying from somebody else. So first of all, the way you were structuring the answer was different. Then suddenly it became completely different because another person came in. So aberrant regeneration. The wiring is now being done by a new electrician. The new electrician does not know the old wiring of the home, so he will wire according to his own imagination. Okay? Now this faulty regeneration or aberrant regeneration can present with two peculiar conditions. The first condition is known as pseudo von Graffi sign, and the second condition is known as pseudo ARP, pseudo Argyll-Robertson pupil. So let's first see pseudo von Graffi sign. What is von Graffi? Before discussing pseudo von Graffi, let me ask you what is von Graffi. Have you ever heard this name von Graffi, everybody? In Graves' disease, thyroid associated ophthalmopathy. Yes? What is von Graffi sign? Lid lag. What do you mean by lid lag, everybody? Let's try to understand this first. Look at my eyes, everybody. When I look down, my eyeballs will go down, obviously. But notice my eyelids. Right now they are straight, eyelids are open. When I look down, everybody, my eyeballs have gone down, but my eyelids have also gone down. Yes? Again, look. Okay? So I say that the eyelids follow the movement of the eyeball. Eyeball, eyelid both go down simultaneously. But due to the fat deposition in the orbit in Graves' disease, everybody, I have proptosis. So my eyes are like this. Now when my eyes are like this, everybody, and I look down, now see everybody, have my eyelids gone down completely? No. So I say the eyelid movement lags behind the eyeball movement. You understanding this? This is called lid lag or von Graffi sign. Something similar occurs in aberrant regeneration of third cranial nerve fibers. Let's see how and let's see why. This occurs because misdirection of fibers occurs between fibers of inferior rectus are misdirected to LPS. Inferior rectus to LPS. So what occurs? On down gaze, both inferior rectus and LPS contract. When both inferior rectus and LPS contract, what will occur, everybody? Inferior rectus, depression of eye. But due to LPS, everybody, elevation of upper lid. You understand what I'm saying here, everybody? So the eyeball will go down due to inferior rectus. But due to LPS, instead of the eyelid going down, the eyelid is actually going up. So it is looking like lid lag. Okay, everybody? Thus, looks like lid lag. That the eyelid is lagging behind the movement of the eyeball, and thus we give it a name, pseudo-von Graffi sign, as simple as that. Yes? So you should know what is von Graffi to be able to understand what is pseudo-von Graffi. Done? Now, let's move on to the second aberrant regeneration manifestation, that is pseudo-Argyll-Robertson pupil, pseudo-ARP. Pseudo-ARP occurs due to fibers of ciliary muscle misdirected to sphincter pupillae. Ciliary muscle misdirected to sphincter pupillae and fibers of sphincter pupillae completely damaged. Are we clear? So we are saying the fibers to sphincter pupillae are completely damaged, and on regeneration the fibers to ciliary muscle instead start also going to the sphincter pupillae. So now two things occur due to this, everybody. What are the two things which will occur? Because the fibers of sphincter pupillae are completely damaged, there is no light reflex. But on near vision, accommodation occurs plus the pupil constricts. So we say basically accommodation reflex present, whereas pupillary light reflex absent. Argyll-Robertson pupil, pseudo-ARP, accommodation reflex is present, but the pupillary light reflex is absent. So it presents like ARP, pseudo-Argyll-Robertson pupil. I hope I'm clear here about this, everybody. And with this, I finish the aberrant regeneration, and that's all about our topic, third cranial nerve palsy. Again, I will emphasize on the same point, start this with the structure of the paralytic squint basic line, that all the clinical features are opposite. If you know the basic, then you can build upon your other information surrounding it, everybody. Okay? Now, once we are done with third cranial nerve palsy, everybody, let's move on to the next subtopic in paralytic squint. Fourth cranial nerve, or I can say trochlear nerve palsy. Fourth cranial nerve or trochlear nerve palsy. Okay? Now, again I will start with where is the nucleus situated. So the nucleus for the fourth nerve, again everybody is situated in midbrain. I hope you know this, guys. It is numbered. Number 3 and 4 in midbrain, 5, 6, 7, 8 in pons, 9, 10, 11, 12 in medulla. Midbrain, pons, medulla. If we go brainstem wise, everybody, midbrain, pons, medulla. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay? In the midbrain, at the level of inferior colliculus. Instead of superior colliculus, it becomes inferior colliculus, everybody. Yes? Then, from the midbrain, it leaves the midbrain on the dorsal surface after decussation, internal decussation of nerve fibers. Yes? So it leaves the midbrain on the dorsal surface. This is the only nerve which leaves the brainstem on the dorsal surface, everybody. That's why this is an important anatomical point. And it shows internal decussation. Then it enters the cavernous sinus on lateral wall, just like the third nerve, but passes through superior orbital fissure outside the annulus of Zinn. So again, basic anatomical points, everybody, in the course of the fourth nerve. It passes on the dorsal surface, shows internal decussation, and does not pass through the annulus of Zinn. Just remember these basic points, everybody, about the course. Now, after it has passed through this, it actually supplies the contralateral superior oblique. Because of the decussation of the fibers which has occurred internally, everybody, I hope you understand that the supply is actually to the contralateral superior oblique. But just like third cranial nerve, only when the lesion is in the nucleus midbrain, then the manifestation will be in the contralateral superior oblique. But if the lesion is anywhere else, intracavernous, intraorbital, which is mostly the case, the ipsilateral superior oblique will be palsied. I hope you understand this. These are my two nuclei, everybody. The nerve is crossing here, and this is my superior oblique. Okay? Right, left. If the lesion occurs here, the right nerve is getting affected, right superior oblique is getting palsied. But if the lesion occurs here, okay, now the left nuclei, but the right superior oblique. Okay? So only if the lesion is at the level of the nucleus, then the contralateral presentation will be there. But apart from that, anywhere in the course, there will be ipsilateral presentation. Okay? Now, clinical features. For clinical features, again, I will use the same line, everybody. Clinical features are opposite to the action paralyzed. Only one muscle will be paralyzed here, SO4, superior oblique palsy. Yes? So only one muscle actions are getting paralyzed. Let's see what are the actions. Number one, what is the primary action, everybody? Superior oblique primary action is intorsion. Remember the mnemonic SIN. Superior muscles are intorsion causing muscles. When intorsion is paralyzed, what will be the clinical feature? X cyclotorsion. X cyclotorsion. I know it will not be visible, but yes, this will be the presentation. X cyclotorsion. Second, everybody. The second action, the secondary action was superior oblique. Obliques have the opposite action. Opposite means depression. Superior muscle causing depression because it is an oblique. There is no depression which is going to occur. Instead, what will occur, everybody? Elevation. Up eye. And up eye is known as hypertropia. Up eye is known as hypertropia. Am I clear? So superior oblique palsy presents with ipsilateral hypertropia. I hope there is no confusion in this simple point. Now, number 3. What was the clinical action? Clinical action, guys. Clinical action. Obliques predominate in adduction. So, depression in adduction is paralyzed. Depression in adduction is paralyzed. If depression cannot occur in adduction, instead what will occur, everybody? Elevation in adduction. See, in adduction, my eyeball can either elevate or get depressed. Elevation in adduction was caused by inferior oblique. Depression in adduction was caused by superior oblique. Now superior oblique is paralyzed, so inferior oblique is overacting. So my eye will elevate in adduction. Or I can say hypertropia increases on adduction. See, hypertropia is a clinical feature. The patient will present with hypertropia. Look at my hands, everybody. My left superior oblique palsy is there. So my left eye is hypertropic already. Now, when the left eye will adduct, there is only one muscle acting. Which muscle, everybody? Inferior oblique. So the inferior oblique will increase the hypertropia. You're getting my point? Again, let's see. This is the normal position. Due to superior oblique palsy, my left eye is hypertropic. And as soon as it adducts, the elevation will increase. Why will the elevation increase? Because inferior oblique is overacting. Yes, so elevation in adduction or hypertropia increases on adduction. Or if I use English in another way, I can say hypertropia increases on opposite gaze. Hypertropia increases on opposite gaze. Opposite gaze, again look at my hands, everybody. Left eye, when the left eye is adducting, everybody. When the left eye is adducting, everybody, it is moving towards which side? Right side. So left eye adduction means left eye moving towards the right side, opposite gaze. So the hypertropia is increasing in adduction, or I can say the hypertropia is increasing on opposite gaze. No confusion? See, again, just the use of English, guys. So this is what trouble students. That is why these hands are important. As I said to you in yoke muscles, if you keep your hands moving during squint, the ability to understand squint will increase. You will retain it much better. Okay? Now, clinical feature number 4, guys. The patient will obviously experience diplopia, but this diplopia will be in vertical directions. To be more specific, I will say patient complains of diplopia while climbing downstairs. Patient complains of diplopia while climbing downstairs. Why? Superior oblique is paralyzed. Everybody again look at the hands. Left superior oblique is paralyzed. So to climb downstairs, I need to look down. The right eye can look down. But the left eye can only partially look down because one of the depressor is paralyzed. Superior oblique is paralyzed. So one eye completely looking down, one eye partially looking down. So the patient is saying, I have diplopia when I climb downstairs. But when the patient will climb upstairs, what will occur, everybody? The right eye is normal again. So the right eye can look up. The left eye can also look up. The elevators are normal. The superior rectus and the inferior oblique are normal. So during up gaze, there will be no diplopia. But during down gaze, due to the different varying levels of the depression, the diplopia will be present. Vertical diplopia. Okay, everybody? Number 5. To adapt, everybody, patient will assume a head posture. Head posture. Okay? Now, let's see head posture. Let's first write down the rule for the head posture in simple English, and then let's understand. Head performs the same action as of paralyzed muscle. This is the way, it is the simplest to understand. Head posture. Head performs the same action as of paralyzed muscle. What do we understand from this, everybody? Look at my eyes. Everybody, focus. Let's say I have bilateral superior oblique palsy. Right now my eyes are absolutely straight. If I had bilateral superior oblique palsy, I can't show you unilateral, na? I can't do one eye elevation, right? So I can only do bilateral elevation. So let's assume I have bilateral superior oblique palsy. So I have bilateral elevation. Look at my eyes. I would have presented to you like this. Okay? When I'm like this, everybody, now I can't see everybody. I can't see anything in the straight. I am almost not able to carry out my day-to-day activities because I can't see here. So what will I do? I will say, let's adapt. Let's assume a head posture like this. Can you understand, everybody? Even with my head posture down, everybody, because my elevated eyeballs now are able to look straight, everybody, I can carry out my day-to-day activities. Where have I moved my head, everybody? I have moved my head down. Yes or no? I was This is what I have done. What is the action of superior oblique, everybody? Elevation or depression? Depression. So the head has performed the same action as of the paralyzed muscle. The action of superior oblique was depression. I have moved my head down. So even with hypertrophy, I can look in the straight direction. You understand, everybody? So this is an adaptation. Adaptation to the problem thrown by squint, everybody. Head moves in the same direction as of paralyzed muscle. Am I clear, everybody? So let's see what will be the head posture in fourth cranial nerve palsy. Head posture A. For depression. For depression as an action, as I just showed you, I measure the level of the chin. Chin up, chin down. So the head posture will be chin depression. Okay? For intorsion. This is where students start to get confused. But if you are putting your head into it, there should be no confusion. Intorsion, extorsion, even though not clinically visible, but my adaptation will have to take place, everybody. So let's look at my hand, everybody. Left hand. Left superior oblique is paralyzed. I'm again and again telling you. That means the intorsion would have been like this. Yes? This is the action of the eye. Can I say, everybody? Normal position, intorsion. Now my rule says the head has to perform the same action as of paralyzed muscle. So everybody, let's see. Let's assume this is my eye. So if this was intorsion, my head will have to move like this. Can you see, everybody? Head is performing intorsion of the left eye now. The same thing that the left eye would have done in intorsion, now my head is doing. Are you clear, everybody? So what is my head posture? I have tilted my head, everybody. Head tilt. Towards which side? Right side. Which is the palsy we are giving an example for? Left side. So what will I say? Head tilt towards the opposite side. Head tilt towards opposite side. Head tilt towards opposite side. I hope you have tilted your head. You have performed intorsion with your hand and tilted your head. Once you do this, you will never forget this, guys. That's the beauty, guys. Just perform it once. You will comprehend it yourself. Okay? Now with third head posture, guys. Let's see the clinical action. For depression in adduction. For depression in adduction. Basically, there are two actions here. Depression in adduction. For depression, we have already seen there will be chin depression. What for adduction, everybody? Again, let's move our hand. If the left eye would have adducted, it would have been like this. Now, this is the action that my head has to perform. So, see my head performing the same action, everybody. Can you see, everybody? So, left eye adducting. Same action. So, what has my head done now? My head or my face, I can say, has turned. It has not tilted. Understand the difference? This was tilt. Now, what has my head done, everybody? Turn. Okay? Turn towards the right side. Palsy left, face turn towards the right side. So the head posture, everybody, is face turn towards opposite side. Face turn towards opposite side. If it is seeming difficult, it won't, guys. Just remember to move your hands. Just remember that the head has to perform the same action as of paralyzed muscle. For depression, for intorsion, for adduction. Am I clear to everybody? No confusion about this should be there. And that's all about the head posture that is seen in cases of fourth cranial nerve palsy. Now, after we are through with the clinical features, what is the treatment, everybody? The treatment of fourth cranial nerve palsy is basically surgical. The treatment is done according to a classification which is known as Knapp's classification. Not going into the detail, guys. Way out of our course, I can say, though nothing is. The most common procedure that is done is inferior oblique weakening. Because the inferior oblique is overacting, we will make it weaker. There are lots of procedures by which we can make the action of a muscle weak. Okay, so inferior oblique weakening is done. Now, After the treatment, the important part is how to test, how to diagnose for surety that it is a case of superior oblique palsy. So the main test that we use, everybody, for the diagnosis is called as the Parkes 3-step test. Parkes 3-step test. This test is popular for superior oblique palsy, but it can be used for any muscle palsy, any cyclovertical, superior rectus, inferior rectus, superior oblique, or inferior oblique. Recently, a question in AIIMS had come which has created a lot of confusion among students. If you would have understood Parkes 3-step test for superior oblique palsy, the AIIMS question would have been literally a cakewalk for all of you. Let's see how. Step 1. Parkes 3-step test. Step 1 says, identify hypertropic eye. In this image, everybody, the first image that we see, we are clearly able to see that the left eye is hypertropic. So we have identified the hypertropic eye. Okay. Now if there is hypertropia, it can actually be a paralysis of either the superior oblique, depressor, or the inferior rectus. How to find out that for surety it is superior oblique palsy? For that we do step 2. Okay. The hypertropia will increase in either right gaze or left gaze. You ask the patient to look towards the right as well as the left. In any one of the gazes, the hypertropia will increase. The rule for step 2 is hypertropia increases in the direction of clinical action of paralyzed muscle. Okay. So if we focus on superior oblique, everybody, what is the function of superior oblique? Depression in adduction. Adduction. So if we are focusing on the left eye, when the left eye performs adduction, everybody, left eye performing adduction, that means looking towards which side? Right, guys. So in this case, on right gaze, hypertropia increased. Let's see in the photograph. See, everybody, when the patient is looking towards the right side, the left eye is performing adduction. Can you see, everybody? And if you see, compared to the right eye, the adduction has increased the hypertropia. Can you see, everybody? For that matter, notice the other image, everybody. In the other image, both the eyes are looking towards which side? Left side. So the left eye is performing which direction of action? Abduction. So when the left eye is in abduction, it is straight abduction. There is no elevation that you can see. Are we clear? Can you look, everybody, that along with the adduction, the hypertropia is increased, but along with the abduction, hypertropia does not increase. So we are saying the hypertropia will increase in any of the gaze, either the right gaze or the left gaze. And the rule is that this hypertropia would have increased in the direction of clinical action. So because the action is in adduction means towards the opposite side. So the left eye hypertropia is increasing on right gaze. Okay. Or if you knew the clinical features, you would not have had to think so much. You already know clinical feature number 3, hypertropia increases on opposite gaze. Am I clear? So it's just the clinical feature being shown in the image. Hypertropia increases on opposite gaze. Okay, everybody? I will just add one word here. Hypertropia increased in left eye. Okay? Now, after we know step 1 and step 2, let's move on to step 3. This photograph. In step 3, we see hypertropia will decrease. Hypertropia will decrease. Hypertropia will decrease. What is the rule? When head tilts in the same direction of cyclical action, intorsion or extortion of paralyzed muscle. So what is the cyclical action of superior oblique? Intorsion. As we have just discussed, intorsion means the head has to tilt on the opposite side. So the hypertropia will decrease in the direction of cyclical action of paralyzed muscle. So if my paralyzed muscle is superior oblique, my hypertropia will actually improve when the head tilts on the opposite side. Head tilts on the opposite side means when the head tilts towards the right side. So this is my head tilting towards the right side. Yes. So you see the hypertropia has improved. But when my head tilts towards the left side, everybody, do you see the hypertropia has actually increased? Am I clear to everybody? So when the hypertropia will decrease? When the head tilts in the same direction of action of paralyzed muscle, just like my head posture, because this is an adaptation. We already know this. So on right head tilt, everybody, the left eye hypertropia has improved. Am I very clear here, everybody? This fundamental can be used in diagnosing any of the superior or inferior muscle palsy. All you need to remember is the two rules, that in step 2, hypertropia will increase in the direction of clinical action of paralyzed muscle, whereas in step 3, the hypertropia will decrease in the cyclical action of the paralyzed muscle direction. Okay. For superior oblique, we can remember it simply by a mnemonic. We say VOOG. Hypertropia is worse or increases on opposite gaze. Okay. Hypertropia increases worse on opposite gaze. And step 3, boot. Hypertropia will become better on opposite tilt. Okay. So for superior oblique, it is very easy. You remember VOOG and boot. Worse on opposite gaze, better on opposite tilt. Am I clear to everybody here? No confusion? Please just apply your mind to it and remember Park's 3-step test. Now, if I show you this photograph, everybody, can you diagnose this photograph for me? This should be easy now, everybody, if you are focusing on it. This is a 9-direction gaze, everybody, primary, secondary, tertiary gaze. Always first look at the primary gaze. Half of the job is being told to you by the primary gaze. In the primary gaze, when I focus, I see the right eye and I see that the right eye is slightly hypertrophic. So there is right eye hypertropia. Now, the right eye hypertropia has to increase on adduction on opposite gaze. So I see right eye adduction. And I ably notice when I compare it to the left eye that the hypertropia has increased. So hypertropia has increased on adduction in the direction of action of the muscle. Step 2. Okay. Step 3, obviously the tilt has not been shown here. So we can't think about that. We can't see that. But there has to be problem in depression in adduction. Yes or no? There has to be problem in depression in adduction. So I move on to this eye. For right eye, this is depression in adduction. Now if you see the left eye here, everybody, the left eye has gone down and has been able to abduct. But the right eye has not been able to go down that much. So it is showing deficiency of depression in adduction. The clinical action is not being able to occur to its full strength. I hope we are clear about this. I hope there is no confusion in this. Yes? That's it about 4th cranial nerve palsy. Now, let's move on to the next. That is 3rd nerve done, 4th nerve done, 6th cranial nerve, or I can say abducens nerve palsy. And actually I will write the third name also. We all of us know LR6, lateral rectus, is the only muscle supplied by the 6th nerve. So I can actually call this topic lateral rectus palsy. Okay. So I hope it is crystal clear here what we are discussing. Again, where is the nucleus situated? No doubt. I've just explained to you 5, 6, 7, 8 is situated in pons, everybody. So the nucleus is situated in pons. After exiting from the brain stem, everybody, the nerve passes through Dorello canal. After exiting the brain stem, guys, the nerve passes through Dorello canal. Then it enters the cavernous sinus, just like the third and the fourth nerve, and runs in the lateral wall. Passes within superior orbital fissure inside the annulus of Zinn. So it's like third nerve. It passes inside the annulus of Zinn. So two important anatomical landmarks, everybody: Dorello canal and inside the annulus of Zinn. Okay, no confusion. Then it will ultimately supply the ipsilateral rectus. Done? Now, obviously only one muscle is getting supplied, so our job becomes easier. Again, when I move on to clinical features, I will ask you only one thing. And that one thing will be to remember the line: all the clinical features are opposite to the action. So what is the only action of lateral rectus, everybody? The only action of lateral rectus is abduction. So there will be limitation of abduction. Abduction means the eyeball will not be able to go out. If the eyeball is not able to go out, everybody, the eyeball is coming in. And all of us know that inward eyeball is known as esotropia. So the clinical feature of lateral rectus palsy, everybody, is esotropia. As simple as that. Okay? No confusion? Now, as soon as I write esotropia and if I write diplopia, and if I ask you which type of diplopia will be there, crossed or uncrossed, again remember X. Exo will have crossed. So ESO, as we have already seen, has uncrossed diplopia. Like we discussed in the Maddox-Scott test, again everybody, esotropia presents with uncrossed diplopia. Number 3, again there will be some kind of adaptation. So head posture. So what is the head posture in case of 6th cranial nerve palsy? Again, just remember the rule of head posture. Head performs the same action as of paralyzed muscle. So let's say my right lateral rectus is paralyzed. What is the action of lateral rectus? Abduction. Okay. This is the action that the head will have to perform. So let's see, everybody. Let's abduct our head. So what has occurred, everybody? I have to turn my head. Turn my head towards which side, everybody? Right side. Where is the palsy, everybody? Right eye, and I have turned my head towards the right side. So what does the answer become? Face turn, but now towards the same side of paralysis. Am I clear? So the head posture is face turn towards same side. Face turn towards same side. No confusion, I hope, everybody. Again, just do this and you will be able to understand this. Number 4, as a fourth clinical feature, I can say there will be ipsilateral, horizontal gaze palsy. Ipsilateral horizontal gaze palsy. Example, right gaze. Right gaze uses two muscles. What are the two muscles used in right gaze, everybody? Right lateral rectus and left medial rectus. So if my right lateral rectus is paralyzed, there is right gaze palsy. So ipsilateral horizontal gaze palsy. Am I clear to everybody? Ipsilateral, same side, you won't be able to look. That's all about the important clinical features of a case of 6th cranial nerve palsy. Only one action, very simple, everybody. Nothing difficult here. Just remember esotropia as the main presenting feature. Just see this image, everybody. Let's try to find out the answer in this image. Let's look at the first image, the primary gaze. Do we see any abnormality in the primary gaze? The right eye is straight. But if we see the left eye, everybody, the left eye, see this, Is the corneal reflection present in the center? No. Yes. Can you see? Again, I'll rub it for you. Now carefully try to see. The left eye is deviated inwards by around 15 degree. Yes. So I will say there is left eye esotropia. Don't jump to the answer. Let's confirm it. Ask the patient to look towards the right side. When the patient look toward the right side, the left eye is performing adduction. And adduction is absolutely normal. So left eye adduction is normal. Now we ask the patient to look towards the left side. In right side, the left eye has to perform abduction. Is there any abduction which is occurring? No. So I am saying left eye abduction is absent. Are we clear here? Because the left eye abduction is absent, I can presume it is lateral rectus palsy, and then it gets confirmed by the esotropia presentation. So it makes it a case of left sixth cranial nerve palsy. Okay? Very easy, guys. So again, this is what I always say to students when they are learning neuro-ophthalmology or squint. When it comes to images of squint, everybody, please take baby steps. Don't try to jump to the answer. If you try to jump to the answer, you will always get the wrong answer. Go sequentially, give it 30 seconds, give it 1 minute, and then solve it. Sometimes a tricky image can come which will look like sixth cranial nerve palsy, but will be something else. I will show you such images. Yes? That's all about sixth cranial nerve palsy, clinical features. To finish the topic of sixth cranial nerve palsy, let's see the causes. Important causes of sixth cranial nerve palsy. 3 syndromes, everybody. Again, anatomy, I am talking about lesions through the pons. Number 1, Foville syndrome. These are sometimes asked, that's why I'm just listing them for you. Foville syndrome. Foville syndrome is a complete transection through pons. It presents with ipsilateral 5th, 6th, 7th and 8th cranial nerve palsy with central Horner's syndrome. Why central? Because brainstem has sympathetic fibers going from the hypothalamus to the spinal cord. So the central part, the first order neurons will be damaged. Second, the second important cause is Millard-Gubler syndrome. What is the presentation in Millard-Gubler syndrome? Ipsilateral 6+7 cranial nerve palsy. Ipsilateral 6+7 cranial nerve palsy with contralateral hemiplegia. And then lastly, everybody, another important syndrome, written Mobius, but O is the French O, so pronounced as Mebius syndrome, bilateral 6+7 cranial nerve palsy. Bilateral 6+7th cranial nerve palsy. Okay, these are the 3 important causes of a case of 6th cranial nerve palsy. With this, I finish the topic of paralytic squint, 3rd, 4th and 6th, everybody. I will summarize it by saying 2 lines for you, everybody. What are the 2 lines I will say, everybody? All clinical features are opposite to action of muscle paralyzed, but the head posture is the same as action of muscle paralyzed. Okay, everybody? So clinical features are opposite, but the head posture is the same. Just remember these 2 things and you shall be able to revise and hold in good stead the topic of paralytic squint. I hope I've been able to make it simple for you guys.